opportunity for me to also present Investigator of the Year award. And so this is an award recognized at the Heart Institute researcher who's really made outstanding research achievements, particularly during the past year. And we're privileged this year to really have an exceptional slate of nominees, and who are all female with most deserving accomplishments. And after much deliberation, we're pleased to present today Dr. Jodi Edwards as this year's Investigator of the Year. Following her postdoctoral training with Dr. Sandra Black at Sunnybrook, she established her independent research career here at the Heart Institute in 2017, focusing on the brain and heart interface. And her outstanding accomplishments the past year, including successful CIHR grants, which really studied the importance of left atrial cardiopathy in defining dementia risk. And it was the top reviewed grant in that panel. And also as a co-PI on CardioDoc project, also CIHR funded project in terms of screening for depression and cognition impairment in cardiology clinics. She is a Heart and Stroke Foundation new investigator, and also received a Catalyst grant on improving women's heart and brain health funded by Health Canada. And she is also a key member of the team on 2 large infrastructure grants that will be announced in the new year. And she published many of the important papers in the field as well, in Journal of American Heart Association, and the defining atrial cardiopathy as a risk for stroke even without atrial fibrillation. And this will have major impact in how we actually think about stroke and dementia risk in the cardiac patients. And she also has advocated and participated for consensus in this area. And she has personally, in fact, launched a Canadian platform for research in non-invasive brain stimulation or cardiac STEM, and recommending the use of repetitive transcranial magnetic stimulation in terms of way to intervene for stroke rehabilitation, complete application of new technology for a very vexing problem. And she is also part of the expert panel for the Heart and Stroke Foundation and many other alliances across Canada to really promote sex and gender aspect of cardiovascular research. And this is also published in the Journal of American Heart Association. And so she is really a very important spokesperson for this area, particularly on the intersection of brain and heart connection, as well as stroke in women. So overall, Dr. Edwards' outstanding work have a major impact on improving heart-brain health for all Canadians. And we are most proud on this occasion to congratulate Dr. Edwards for this important recognition. So I'd like to hand the award to Dr. Edward. Wow, look at that. Fantastic. That's an instant transmission. And so now I'd like to invite Dr. Edwards to give us a much anticipated Investigator of the Year lecture. And it's entitled Interdisciplinarity and Brain-Heart Connection, Insights into Risk Prediction, Treatment and Outcomes for Brain and Heart Disease. Dr. Edwards.
Well, thank you so much. I'd like to thank the committee for this recognition and all of my colleagues, as I said, deeply honored to receive this award and give this lecture today. I'm just going to share my screen. Okay, can everyone see that?
Looks good.
Okay, great. Thank you, Peter. Okay. Well, thank you so much. I'm going to talk a little bit today about the journey that led me here to the Ottawa Heart Institute to establish my program in brain and heart research, and also some of the many things that we're doing in the program in my lab to try and tackle this complex problem and the road ahead. So I remember 3 years ago this month, when I first started my program here at the Ottawa Heart Institute, I was meeting with Peter in his office, and we were discussing the initiation of my program and how this program was going to kind of align with the current work ongoing at the Institute. And at the time, Peter was developing the new Oracle strategic plan for the Institute, and he had this grid up on his whiteboard. And it had sort of different squares of different strategic areas of focus that the Institute wanted to try and advance knowledge in, build capacity in. And as we talked through my program, you know, everything started to check, all the little boxes started to check. And I said, okay, well, population health, yes. Women's heart and brain health overall. And it just seemed that my program seemed to check all the boxes. And it's really a testament, I think, to the interdisciplinarity of epidemiology. I think that's one of the things that attracted me to do my doctoral work in epidemiology. It's highly interdisciplinary and highly collaborative. You really can't not be collaborative in epidemiology. And we have really seen how much innovation is sort of born from interdisciplinarity over the past several decades of medical research, and potentially none as much as this year. Really, now since the global pandemic, epidemiology has become a household term, and people no longer think I study skin, which is wonderful. But you know, in this time, it's become very apparent, of course, you know, how much impact public health has on population health, and how much interdisciplinarity and global collaboration can really perform you know, miracles in terms of our vaccine development and this time. So my interdisciplinary academic journey really began, perhaps fitting to this year's research theme, out in the West, in the Wild West in Calgary, Alberta, where I did my undergraduate and master's degrees. And the first lab I worked in was of Dr. Penny Pexman at the University of Calgary. And she really taught me the foundations of behavioral cognitive science. And from there, I was able to work with the world-renowned Calgary Alberta Stroke team, and develop an expertise in neuroimaging. And arguably, Dr. Michael Hill and Dr. Andrew Demchuk are two of the global leaders in terms of stroke trials. And I remember Michael always teaching me to think of the underlying biological mechanism always. So from there, I moved to Montreal, across the country, and began some work at the Montreal Neurological Institute, again, you know, developing further expertise in neuroimaging techniques, and where I met my CanStim collaborator, Dr. Alexander Thiel. And then I decided to become even more interdisciplinary and pursue a doctoral degree that was a joint degree, both in the experimental imaging and neuroscience techniques that I had been doing, and in epidemiology. So I moved all the way back across the country to the University of British Columbia, where I worked with Drs. Lara Boyd and Dr. Mika Kuhorn. And Dr. Boyd taught me the fundamentals of transcranial magnetic stimulation, which I still use today as one of the core methods of my program. And she always taught me to think of everything from the patient perspective, which was a very important lesson. And Dr. Kuhorn was the first to teach me sort of the foundations of data science and epidemiological research in terms of the use of linked population databases. And as a sex and gender chair for CIHR, she also taught me the importance of bringing that lens to my research. So once I completed my doctoral studies, I then, as Peter indicated, started postdoctoral work at Sunnybrook Research Institute in Toronto under the supervision of Dr. Sandra Black, the incomparable Dr. Sandra Black. So Sandy, she taught me all about the neurovascular unit and really how to think as a visionary thinker. And she taught me how to do all of this and be just a lovely person at the same time. And I had several other really key mentors at this time at Sunnybrook, and including Dr. David Gladstone and Dr. Jeff Healy, who really first initiated me to the importance of cardiac markers of stroke risk, and started me on my journey towards the brain-heart connection. Dr. Moira Caprell, who really has been a key ICES mentor in terms of data science approaches. and Dr. Rick Swartz, who is my co-collaborator on Cardiac Doc, and who has just been a mentor in every aspect of pursuing this work, and really teaching me how to manage and advance really complex moving part kind of projects. So building on all of this fabulous mentorship and guidance and these methodological techniques that I learned, I then moved just up the road this time to establish myself and find my new academic home here at the Ottawa Heart Institute. So it was here that I first began the Brain and Heart Nexus research program. And so in thinking about the brain and heart, as I said, it's a very complex clinical question. So the brain and the heart are complex physiological systems in their own rights. And then of course, the interconnection between them becomes from top down autonomic signaling and bottom up with the vasculature becomes an even more complex clinical problem. So the way that we've tended to approach this problem is just in a very systematic way throughout the translational pipeline. So in my lab, we approach this on sort of a multi-pronged, comprehensive, multiple fronts. We work on identifying novel cardiac markers of stroke and dementia risk and validating those markers, then characterizing some of the high-risk phenotypes for brain-heart comorbidities. We want to evaluate how these high-risk phenotypes might differ in terms of their treatment response, or do clinical prediction modeling to determine how we can tailor personalized treatment for these individuals, and ultimately with the goal of course, improving outcomes for individuals with cardiovascular, particularly brain-heart comorbidity. So in terms of risk markers, we've been, as indicated by Peter in the introduction, quite focused on atrial fibrillation and atrial cardiopathy as an important risk marker of brain health. So motivated by the fact that atrial fibrillation confers such a substantial stroke risk, we were focused in on the fact that all the clinical decision making around anticoagulation or management and prevention in this population was really hinging on establishing that diagnosis of atrial fibrillation. However, as we've noted in some previous work that we published back in 2017, there's really an underutilization or underdetection of atrial fibrillation. And then even if you do happen to detect someone who's in manifest atrial fibrillation, there's actually many for which this risk is still apparent, but the underlying problem is silent. And so there's been a lot of increasing evidence that subclinical atrial fibrillation actually confers a substantive risk of stroke independent of established atrial fibrillation. So having atrial fibrillation and decision-making kind of hinge on the established definition is potentially problematic. So we wanted to explore additional risk markers that might be helpful. So as mentioned, these are the current guidelines for anticoagulation use in atrial fibrillation. And we wanted to just focus in on the use here of the present risk score, the CHADS-VASc score, and determine whether or not the addition of markers of earlier subclinical disease, so some structural changes or electrical changes that occur prior to the onset of atrial fibrillation, which is often termed atrial cardiopathy or myopathy. We wanted to determine whether or not they might improve the predictive utility of the CHADS-VASc. And this paper was published earlier this year in the Journal of the American Heart Association, and confirmed that indeed, when you do add markers of cardiopathy to this risk equation, you get increased predictive utility. So for every 10 millimeter increase in left atrial size, it conferred a 72% increase in cause-specific stroke hazard at 2 years and an 87% increase at 5 years. And this was independent of the diagnosis of atrial fibrillation. So this really kind of contributed to the literature for and support of this new model of thromboembolic risk in individuals with AFib or even with subclinical disease. And so confirming that this abnormal atrial substrate is a significant predictor of stroke risk, and that may or may not be mediated through manifest atrial fibrillation. So we noted as well the substantive literature showing links between atrial fibrillation and dementia risk, and wondered if there was additional nuance that we could derive in terms of this abnormal substrate for cognitive decline and dementia risk. And this was submitted to the CIHR, as Peter mentioned, and was successfully awarded a project grant earlier this year, investigating the utility of markers of left atrial cardiopathy to estimate dementia risk. So we've already initiated some work along this line in terms of compiling the literature and conducting a systematic review, looking at several candidate markers of atrial cardiopathy and some of the cerebral small vessel changes that we observe on MRI associated with cognitive decline. And this work was really led by some of the trainees within my lab, and it was led by a summer student last summer, Zainab Danhab, and Dr. Lisa Sheehy, who's my research coordinator, and my master's student, Danielle Marianne. So this work is just in submission, and from here, we are going to begin work on the full project for the CIHR grant. So we've obtained access to 2 large prospective cohorts from the United States, the Regards cohort and the Cardiovascular Health Study Database. And from here, we're going to start developing these clinical prediction models, looking at various markers of cardiopathy and looking at trajectories of cognitive decline. So this work is going to be led by my new fellow, Dr. Claudia Lee, who joins us from Western University and was the successful recipient of an endowed fellowship just a couple of months ago from the Institute. Other markers of interest within these databases that we would really like to explore are blood and imaging based markers of blood-brain barrier permeability. So there's been some work establishing that individuals with atrial fibrillation may have vulnerability in terms of a leaky blood-brain barrier, and some of the markers of interest have been on CT perfusion, permeability surface area product, or some serum markers such as IL-6 or glial fibrillary proteins. And so this work, we're going to look to incorporate into some clinical prediction models, and this is going to form the basis of the master's work for my student, Danielle. Now, once we've identified some risk markers, we really want to further characterize who is a high risk phenotype and what phenotypes are at greatest risk. So the 2 populations that we are very focused on in the lab are those with multimorbidity, and of course, as Peter mentioned, women's heart and brain health. The first major project in this regard in terms of multimorbidity is the cardiac doc study. So this is in collaboration with my co-PI, Dr. Rick Swartz from Sunnybrook Institute, and also Dr. Lisa Mielnicek here at the Heart Institute is a co-investigator on this grant. So this grant evaluates the heart, and it focuses on the heart failure population, and notes that this population is very vulnerable to having multimorbidity, several chronic conditions, and that many of these individuals have a high burden of non-traditional cardiovascular risk factors. And the 3 most common among those are depression, obstructive sleep apnea, and cognitive impairment, or DOC. So given the high prevalence of these comorbidities and the fact that we know that each of these comorbidities confers substantive risk in terms of hospitalization, functional outcome, and even mortality in this group, we focused on the fact that these 3 conditions are actually frequently unscreened and undetected. So individuals with a complex heart failure regimen that they're trying to maintain at home in the context of cognitive decline may be struggling to have optimal management and may be vulnerable to rehospitalization and adverse complications. So this first grant, we received a pilot grant that was an Oracle funded grant and also bridge funding from CIHR. And we wanted to just determine initially whether or not a rapid screening test that we developed, 1 page in 6 minutes, could identify these conditions and triage individuals as high risk for these comorbidities. So with this funding, we successfully established our primary endpoint, which was feasibility of the screen, and that 89% of individuals in complex care clinics were able to complete the screen in under 6 minutes. And we were also able to establish our secondary endpoint, which was characterizing the sort of prevalence of these three comorbidities amongst the heart failure population. And notably, almost 30% of them presented as high risk for cognitive decline. So from here, we've actually scaled this project and leveraged that funding. We've scaled it up to another CIHR submission, which is pending. It's, it's under review at the moment, but we're really going to move this from characterizing the high risk phenotype now into clinical prediction. For this, we've actually had a couple of other collaborators join our team, experts in heart failure, Dr. Douglas Lee and Dr. Heather Ross. And we're going to leverage their existing clinical trial networks and expand this up to a multi-site study in addition to Ottawa and Sunnybrook, where the initial 2 sites were. We're going to look across 12 sites and start to conduct screening, both in the primary and secondary care settings, and then link these data with ICES to really develop clinical prediction models. And for this, we're not focused as much on mortality as a lot of the clinical trial data has indicated that, that there's cardiovascular mortality isn't mitigated as much with treatment of depression and cognition, but we're focused on mitigating risk of ambulatory care sensitive conditions. So these are indexes of avoidable morbidity. So these are things that lead individuals to have a hospitalization, have a poorer quality of life, such as dehydration, pneumonia, complications of diabetes. So these are the outcomes of interest that we're looking to predict with these comorbid conditions. Another set of studies that we're looking at in terms of high-risk phenotypes is collaborative work with my good friend and colleague, Dr. Thais Coutinho. And this is work that's led by our PhD student, Amy Johnston. She is focused for her dissertation work on a population of women with hypertensive disorders of pregnancy. And so we know from past work that these conditions they confer a substantial risk of cardiovascular complications in a very short time frame postpartum, but there's less knowledge of the risk of atrial fibrillation in this population. And also Amy's going to really get quite sophisticated in mapping out the dose response and some of the mediation effects to really advance the literature in this area and be able to help us develop targeted tools for women with this condition for risk prediction. This work was funded last year by the Canadian Cardiovascular Society, and Amy this year was the successful recipient of both doctoral awards from the CIHR and also the Ontario Women's Health Scholar Award. So she is well on her way in establishing herself in this area. Related to that, as Peter mentioned, we've launched a national network for women's cardiovascular health through the Canadian Women's Heart Health Centre, and it's called the Canadian Women's Heart Health Alliance. I'm an expert member of this committee as well with Dr. Coutinho, who chairs this committee, and we really have gathered clinicians and researchers across the country who are focused on women's cardiovascular health, and we completed earlier in the year this really kind of seminal work, The State of the Science in Women's Cardiovascular Disease, which was an environmental scan looking across the entire literature on the impact of sex and gender in women's cardiovascular health. And this was published in the Journal of American Heart Association with many, many authors who aren't all listed here, but I was very pleased to be a part of this collaboration. And so one of the clear gaps that was noted in this State of the Science position document is a real gap in terms of sex-specific risk assessment tools for women at cardiovascular risk. And this is particularly apparent for women who do have brain comorbidities in terms of their quality of life. So in my lab, we decided to tackle this problem. And we're going to focus on women with heart failure and try and first of all, characterize what kind of brain comorbidities they are presenting with, and look at sex-specific predictors of comorbidities of depression and cognition in this population. And then we're going to develop population-based prediction tools to look at quality of life, self-care, and institutionalization amongst these women. And this is work that's part of the National New Investigator Award that was awarded to me by the Heart and Stroke Foundation and accompanied by a seed grant for women's heart and brain health. And this is work that's going to be led by my new fellow, Dr. Vitrine Tsung, and who she's going to work closely co-developing some of this with knowledge users within Heart and Stroke Foundation so that this work has the direct implementation and the most impact. And once we've characterized the high-risk phenotypes, another element that we do is to examine along that translational pipeline how these risk groups undergo treatment and what kind of response they have for treatment and what their long-term outcomes are. So building on some prior work that we've done in terms of evaluating antihypertensive therapies and different use of diabetes medications and outcomes in people with brain and heart comorbidities. This work we recently conducted in collaboration with Dr. Walter Swartweger and Dr. Brad McIntosh from Sunnybrook Research Institute. This is ICES work where we wanted to understand what comorbidity in the stroke population, what impact it has on long-term outcomes, and specifically amongst some of those high-risk phenotypes. So we derived a cohort of individuals who presented with stroke, who had comorbid depression and diabetes, and we identified 3 high-risk subgroups. We wanted to understand sex-specific effects, the effects amongst young adults with stroke, and also those with AF. And we evaluated mortality, LTC admission, and dementia outcomes. And this has led to a very recent publication in Stroke that showed that depression and diabetes sort of cumulatively converge to substantially increase the risk of independence loss and dementia post-stroke. And there's another publication that's currently under review in the Journal of the American Heart Association, looking at this even amongst individuals younger than the age of 65. So the impact of these comorbidities begins quite young and has a substantive impact on individuals' independence. Some final work with respect to treatment response using these epidemiological methods and ICES databases is in collaboration with Dr. David Mizika-Zetoun here from the Ottawa Heart Institute. And we're, instead of looking at medication treatment in this case, we're actually looking at surgical intervention. And we wanted to compare the use of surgical intervention for valve repair and TAVI, which is a newer non-invasive approach. And we're looking at this with respect to long-term complications and mortality. And a sub-study of this in collaboration with Dr. Nair and Dr. Amufla, who's his resident, who's now, or fellow, excuse me, who's now in Vancouver, is looking specifically at the TAVI population and the treatment response with respect to anticoagulation use post-surgery. So these are some of the secondary analyses and with retrospective databases that we're doing to really evaluate the treatment response in high-risk phenotypes. And then we also have, as Peter indicated, a prospective platform with which we're advancing, and we're looking at treatment response to using a certain type of brain stimulation intervention. So this is based on work that I conducted during my PhD time at UBC that really established initially that with the use of transcranial magnetic stimulation, intracortical excitation is a risk marker for recurrent stroke risk. So this was almost 10 years ago now, but shows you how that translational pipeline you can really advance. So we first established this as a risk marker almost 10 years ago, and now we're coming down the pipeline and ready to test the treatment response and the impact on outcome. So to that end, we established the Canadian platform for the use of non-invasive brain stimulation called CanStim in 2017. And this is a large national platform that seeks to build capacity for the use of these interventions in stroke rehabilitation trials. So just coming out this month in NNR is our first, we held a consensus conference in 2017, compiling our network of investigators doing this type of research across Canada. And we derived a consensus-based process to develop recommendations for clinical trial protocol using this technique. And this document is now just in publication this month in NNR and forms the basis for our first platform trial. So this platform has been designed and as a very interdisciplinary, transdisciplinary and integrated pipeline with both a preclinical arm and a clinical arm. And using the protocol that we derive from the consensus recommendations, we're then going to test some of the gaps in the recommendations in the preclinical arm and modify the protocol and move forward in the clinical front. So this is a highly integrative, collaborative platform. And as Peter mentioned, There'll be some exciting announcements in terms of infrastructure funding for this platform coming in the new year. And this platform will go across multiple sites across Canada. The clinical sites range from British Columbia all the way to Quebec. And we have 2 preclinical sites, one in Ontario and one in Quebec as well. So with that, we'll be launching in January 2021 our first feasibility trial on this platform, which is called the ContraStroke trial. And this will test, we will randomize individuals to receive stimulation or sham stimulation across a 15-day session, and then evaluate stroke outcomes. And as indicated, this is really just the first kind of venture for this platform. Once we've established the platform itself, then we can expand out to other non-invasive brain stimulation techniques and other indications as well, including cognition. So it's been a very exciting year, and all that's come together, you know, for my lab in the last year, and I'm very excited to see what's going to happen in 2021 and beyond. We're going to continue to approach the brain-heart interface and you know, investigate along the translational pipeline, from risk markers to defining high-risk phenotypes, looking at treatment response, and developing clinical prediction models, and hopefully having an impact on patient outcomes. And so I'm also was very honored this year within the Heart Institute to be named as the co-director of the UOHI Population Outcomes Research Unit. And so with the Heart Institute's commitment to build capacity in this area, I think there's going to be lots of exciting work to come. And as mentioned with CanStim, once we've only just established the platform, and there's a lot of growth potential in terms of clinical trials capability, and establishing this platform as really a global leader for multi-center trials in this area. So I'm very grateful that I established my program here at the Ottawa Heart Institute. And I've always been very proud, because the Ottawa Heart Institute, as everyone knows, is really internationally recognized as a leader in clinical cardiac care, and a research leader with exceptional you know, research capabilities, as indicated. But this year in particular, I feel that it's demonstrated its exceptionality in other ways. So this year has been a very challenging year for many people. And I don't think that there's many institutes where the CEO and the scientific director would meet individually and have roundhouse meetings with all the investigators to specifically ask, what are your challenges right now? And how can we support you right now during this time? And I don't know of many other places as well where you would have so much you know, expertise and collaborative work together, and have it feel like such a tight-knit community still, even though we're apart. And I also don't know of many places you know, where individuals have been so supportive of me personally in the last year. When I got so sick with COVID-19 and struggled with my recovery, I had many wonderful, lovely messages and people checking in on me all the time. So I'm extremely grateful for all of the research success in this last year that has led to this award. But I'm also perhaps more grateful that I've been able to establish this program here at the Ottawa Heart Institute with all of my incredible colleagues here. So in closing, I'd like to again acknowledge my research team, Dr. Lisa Sheehy, who's my clinical coordinator, and all of my trainees. And I'd like to lastly close with my most tight-knit collaborative community, which is my little family, my husband Pierre-Luc, my son Joshua, and my daughter Gabby, who have been with me on this entire academic interdisciplinary journey, and also my family out in Alberta, my parents who are listening today, who I haven't seen in a very long time, and hope to be able to see them again very soon. So thank you to everyone, and I would welcome your questions.
Wow, thank you so much. That's just been exceptional. And you know, so I know when we have Zoom meetings, it's very difficult to hear the round of waves of applause, but I can hear them virtually. Yeah, it's just fantastic and just so well deserved. And I think really a testament of how much innovation and the collaboration you can actually generate, you know, just from great ideas. And you really kind of, forged a new frontier in this entire field in a way, so I think other people have to be warned that, Jodi is coming and she's going to be running the show in terms of this entire brain and heart connection. That's really so exciting. And I think that's well recognized, certainly by the papers, by the grants that you have obviously received, through really some of the tough peer review competitions. But at the same time, it really shows how you can actually inspire young people, including those amazing folks at your home, and overcome, not only personal, but really, sort of career challenges. But most importantly is actually, bringing everybody together in your collaborative projects, both at the Institute as well as across the country and internationally. And I think there are very few people that's left, who are actually not part of your research program. So this is just absolutely unbelievable. And this is just the beginning. And so this is really exceptional. And thank you so much, for taking the risk and joining us. And but we have really enjoyed, sort of all the interactions with you. And congratulations again. And look forward to more amazing things down the road. And so I know Jodi has sort of a committee meeting at 1 o'clock, so we'll entertain some questions. And indeed, there are some questions. Oh, actually, Robin Lance, just a big congratulations, Jodi. And the question is, have you, reached out to some of the stroke leaders in Ottawa? And of course, Ottawa has been the home of previous stroke network, and you have, worked very closely with the stroke network as well. And particularly, in terms of your randomized trials and those opportunities involving the stroke community. Yeah.
Yes, thank you for the question. Thank you for the nice congratulations, Rob. Yes, so Dar is in fact part of CanStim. So he's one of the individuals on the consensus group. And he's been in consultation with us around acquiring the imaging protocols for our trial. The trial itself is going to be established. Our site here in Ottawa is going to be at Bruyere Research Institute, and we've been working closely with the clinical team there and Dr. Heidi Sveistrup to get established as a clinical trial site there. And I also was recently appointed as an affiliate investigator there. So with DAR's help, our imaging pipelines are in place, and we will begin recruitment hopefully within the COVID protocols in the new year at Bruyere.
Yeah, I should just kind of as a subtext to that, I hear back from Heidi, she's so thrilled that, you are part of her institute as well. And but also from Ruth Slack, in terms of the Brain and Mind Institute, that how much they appreciate, your input and participation. So I think it's just universal, exciting comments. So maybe I can ask a question, and that is that I really now, and I actually learned a lot, from you, but now I've been much more kind of interested in understanding some of this. Part of this is because, we work on atrial fibrillation biomarkers and, and learning from everybody in arrhythmia and, from you in terms of dementia. But it seemed to be that there is actually this very tight, sort of a circuit connection, between kind of the brain function, with the cardiac function and the systemic issues like diabetes and of course, related to the vasculature. And so now, when we actually, sort of look after our patients, we really actually see these components are so interrelated. So I was looking after some patients, whether they had MI or had they're going for a TAVI, for the valve, but sort of their cognitive impairment, sort of mental status, and all these things are so critical in terms of decision making about how to manage those patients. But one thing which I'm curious is that previously we always thought conditions like heart failure, there's no hope for these patients. Similar currently we kind of think of dementia, it's kind of a sort of one-way street, but that's no longer true anymore. Certainly, in terms of heart failure, we're turning, the clock back for many patients. So I'm curious in terms of what you're thinking in terms of dementia. Are there ways in which we can potentially, sort of improve this circuit in a way by either, correcting their cardiac condition, in terms of making impact on, on the dementia trajectory, or are there other things that in fact can, affect dementia, which then will make actually, their cardiac care easier?
Yeah. I think it's an excellent point. I think there's a lot that actually can be done and inroads that can be made, because what we've seen is, well, unfortunately, the therapeutic clinical trials for dementia treatment have not borne out in terms of very many effective direct therapies to sort of mitigate the amyloid accumulation and things like that. But what we have seen is that when you look at the neurovascular unit as a whole, as Sandy would have me think to all the time, is when you mitigate some of the impact of the cardiac function and boost and stabilize cardiac function, then really what you get is quite a stabilization and a delay in the progression of disease. So while there might not be reversal therapeutics available at the moment, what we can really do is stabilize individuals and delay the progression of the advancement of disease. And so we're working very closely to identify some of those markers as shown in the systematic review, markers that are associated with some of the cerebral small vessel changes that we notice in the cerebrum, and really slow the progression and allow people to live independently for longer, maintain their quality of life, and really work and within the disease and manage it.
Yeah, so a follow-up question from Rob is kind of similar to, the similar theme. One is that currently we only pay attention to kind of a risk factor management, for patients with vascular dementia. And do you foresee that there are things beyond vascular management that can actually impact on dementia, which is a big challenge for many of our patients? And I don't know, do you think, for example, magnetic transcranial stimulation or other things might actually have a potential impact down the road?
Yeah, I think that, obviously the management of risk factors is paramount, but beyond that, I think we're getting a lot closer to, as we've shown, some of the critical risk markers that can then be used to develop targeted therapies, whether or not it's related to, as I mentioned, the cardiopathy and cardiac mechanisms of hypoperfusion, or some of the small vessel changes that are going on, or whether or not it's related to the augmenting therapies of stroke recovery, which, as you know, then leads to sort of this cascade in terms of cognitive decline post-stroke. So brain stimulation is certainly one of those that we're extremely interested in determining the added benefit that might be in addition to rehabilitation, in individuals who are at risk. So I think there's a lot of work advancing on several fronts that, in combination with risk factor management, will really start to move the needle on this for individuals with these conditions.
Right. Okay. And maybe as a final question, so do you foresee down the road, and I think, you are already kind of doing the cardio doc, as a part of the first stage of kind of a co-management, right? Sort of identifying risk. And we kind of put this out there, certainly for our a grant. But do you foresee one day that the dementia experts, so the vision we kind of put in place, sort of the folks who understand the dementia, folks who understand the mental health component, and the cardiovascular experts can actually work together. Generally, this is always a big challenge. So cardiologists never trusted endocrinologists, but now we kind of take over endocrinology. Cardiologists don't want to pay any attention to diabetes, and now, cardiologists probably going to take over diabetes as well. And so cardiologists right now don't pay any attention, really to dementia. It's kind of just something that you have trouble getting a consent, from. But do you think that, in fact, these fields will actually blend in the future?
Oh, I hope so. I mean, I think it's critical that they do. So as I mentioned at the very beginning of my talk, I think that innovation really lies in interdisciplinarity, and the way that that our service provision has been established and as quite a siloed structure to date, I think really limits our ability to capture some of the connections between these systems, and limits our ability to kind of capitalize on opportunities for prevention and treatment at this interface. And so I'm very hopeful that, as we contribute to this evidence and moving forward, that this will kind of create changes in terms of our practice structure and how we deal with individuals with comorbidity, and really moving towards a more interdisciplinary care team approach, and kind of tackling this to optimize prevention and individualized prevention for people with different kinds of comorbid conditions. So that would be my hope for sure.
Yeah, so it's really bringing together, sort of the precision medicine aspect and the, multidisciplinary patient-centered care, all together in one setting. And that, so I would say, really these are domains that matter the most, to the patient as well, in terms of their, not only their survival, but their quality of life. Yeah.
Mm-hmm. Exactly.
Okay, so this has been wonderful. And so I think you have educated us all on this very, very important area. And thank you so much for forging the frontier. For all of us, certainly opened my eyes. And it's been an exciting journey. And this is truly, I think, opening the door for everyone. And look forward to more, collaboration and more new tools and new solutions, for these important challenges for not just for our own patients, but in fact patients globally. So congratulations again, and thank you so much. All the best, and the best to your family during the holidays as well. Yeah, and thanks for everyone who joined us on this occasion. And I think this is a moment of celebration through some very challenging times. And but there's no question that hope and joy is around the corner. And I think we will have a whole new vistas, open for us in 2021. Thank you so much. Take good care, everyone.
Thank you.